progress in controlling the HIV epidemic in Uganda. However, we still see the prevalence increasing in those key population, mostly the sex workers and then the transport workers. So the use of multiple HIV services has been found to HIV services, transport workers. So our general objective was to investigate the factors that influence the use of multiple HIV services among transport workers. And our first objective was to determine the extent of utilization of multiple HIV prevention services and identify the factors that are associated with the use of multiple HIV services. And it was carried out in 4 slum areas of Malala City. That was Chizungu, Luti, Chianja, and Kakoba. You realize at the same time those are hotspot areas where we have a number of sex workers, and there are also stages for those people who drive trucks and then taxis. So we had a population size of 424, and we included all the adults who were between 18 to 54. We used a research administered questionnaire, and we got our ESICO approval from us to REG. Our data collection started in November 2021 and then proceeded February 2022. We had in our independent variables, which were the demographic factors. We had knowledge, awareness, perceptions, and stigma. And then our primary outcome was to use of multiple HIV preventive services, whereby here we are asking participants how many HIV services they have used in a period of 12 months. So, and these were our results. So from this study, we found out that the most age group was between 25 to 34. Most were single, and they had attained primary and secondary level of education, and most were border drivers. And we found out most people had used only one HIV preventive services. And the most common used service at the moment we found out it was condom. The sources, we found that most of the participants that we interviewed, they had obtained their services from a live sex. So I think that's why we still have, or we recorded a higher HIV prevalence in transport workers. So these were, we identified factors that predicted the use of multiple HIV services, where we did multivariate, and then we went to multivariate. The significant items that we got at multivariate, we ran them into the multivariate poison regression, where we had 3 models. In the first model, we enrolled demographics, and the ones that remained significant, we combined them into our second model, which had knowledge, perception, stigma. So, and then we again ran the third model, and we came up with the predictors that were associated to the use of multiple HIV services. So, and according to this table, you can see that participants who were married were more likely to use. So on the level of education, you would see, we found out that participants who had obtained primary or secondary level of education, they had used 2 or more of the HIV preventive services, unlike those who are not going to school. Also, being aware, we were asking about the participants how many services they knew or they were aware about. So a participant who knew more than 1 of the HIV preventive services, when we did our multivariate, it was found out that those participants had used 2 of the HIV preventive services. So still on knowledge, we found out that the participant who had good knowledge was more, or they had used 2 services. Also on stigma, the participants who perceived high risk of getting HIV was found to have used at least more than 2 of the HIV services compared to someone who had low stigma. That at least use of behavioral factors appeared more influential than any other individual level factors for the use of multiple HIV prevention services. So we recommended increased awareness and also modify behaviors of these transport workers if we are to achieve maximum utilization of the HIV prevention services. Thank you for listening.
I think the next presenter will go. We shall ask the questions at once. So the next presenter is...
Thank you very much. Good afternoon. My name is Henry Kalungi. I coordinate VMMC in Mubende region and Rwenzori region under Beila, Uganda. So I want us to discuss VMMC and Shangring device in particular. Well, we're going to look at Shangring device as an alternative to conventional surgical method to increase voluntary medical male circumcision uptake for HIV prevention, and the story is for basing on the Rwenzori region. Next slide, please. Well, I think accelerating VMMC uptake for HIV prevention requires onboarding of various scientific evidence-based interventions, and the use of Shangring device is one of the interventions that was brought on board, and with support from CDC and Ministry of Health, Uganda is really rolling it out. I think started around 2-3 years ago, and it's really gaining pace despite a few challenges here and there. So in 2021, Beila, Uganda, with support from CDC. So important to notice that by the end of January-March 2021, Shangring device uptake was low. In this, I want to describe the rollout efforts in having us achieve this and try to improve performance. Next slide, thank you. So this is a fishbone analysis that followed root cause analysis that the team at the facilities sat down, and we categorized this into 4 areas, one being people factor, the other one was material, methods, and environment. It was due to the limited or no Shangring supplies, then the no Shangring IEC materials that are really critical in health education sessions. Then in the environment, we discovered that there was actually very limited community awareness about this other mode of VMMC implementation. Then, under methods, clear sort of follow-up plan for clients worked on using the Shangring device. Then for the people factors, there was a knowledge gap among the health workers and the VHTs. These are really key in giving out information about these services. And of course, there was no skill in Shangring operation. Next slide, please. So under the methodology, we now had to conduct a training. This was done at the 4 sites in the Rwenzori region. And we also included, on top of the trainings, there were ongoing mentorships that were done to bring on board as many health workers and VHTs as possible. Then with support from CDC and USAID, the Shangring specific sites through the supply chains were delivered to these sites. And the sites were mentored on projections so that we really minimize stockouts and as well as times to document the processes that we are going through and the registers, to update the registers and the data tools, and also conduct monthly data reviews to assess our progress towards utilization of Shangring devices. Then for the follow-up, an adverse events reporting system at each of these sites. So that, it was quite of a new method coming on board, so it needed really somebody who timely responds to concerns and, can trigger the follow-up system once an adverse event has occurred. Next slide, please. So what did we observe? This is an interesting graph because we realized that at the start, when we conducted the RCA and focus group discussions with the Shangring site teams, we started seeing a progress towards improving Shangring uptake. And by the October-December 2021 quarter, we were active and monthly Shangring data reviews were being done. So we see a spike in the uptake and an improvement of Shangring device, which peaked in the April-June quarter 2022. Then we realized a drop, and this drop was basically due to the limited supplies. This was a national issue, outreaches, which were really bringing us numbers before the July-September quarter. So that, however, did not really go down to date. We still maintain a steady flow of clients above the quarterly targets, averaging at around 700, 600 clients. So by age group, you realize that in the highest number recorded in this period is between the 15 to 19-year age group. And we also noted an increase in declining trend versus the increase in age. Apart from the 10 to 14-year age group, where Uganda is participating in a sort of, should I call it a sort of a survey being done in sub-Saharan Africa, where we have a few sites that are piloting Shangring uptake in the 10 to 14 age group. From 15 years to 30 plus, you realize that the Shangring uptake kept declining in Rwenzori region. That's what this particular slide tells us. Next slide, please. Okay, we can continue. So in conclusion, we need to really build capacity of staff through Shangring device skills trainings and mentorships, equipping Shangring circumcision champions and VHTs with information, regular availability of supplies. I talked about routinely forecasting need, then provision of IEC materials and robust Shangring customized follow-ups. They need to be really as intense as possible so that since it's a new method on board, so that clients really can opt for it. Then we also look that we needed the deliberate and intentional investment in Shangring device method as an alternative to conventional surgical method, because it really brings in people who initially could have feared the surgical method, because, for example, there are no injections given, we use a cream, and the waiting time is low, and lots of very much. Over to you, Chair.
Thank you. I think the next presenter is Jamil from HF Uganda.
Thank you. Good afternoon, everyone. Jamil Balgebe is my name. I work with HF, Uganda Cares. as a prevention program manager. We actually undertook a study that we are here to present, and it is a high risk of HIV transmission among partners of people living with HIV and people in detention, temporary detention centers or places. So, globally, we actually know that key and vulnerable populations and their partners contribute the biggest percentage, actually up to 62% of new infections that are occurring among members of key and vulnerable populations. And in Uganda, about 5.8% of the prevalence and was among key and vulnerable populations. And among key populations, HIV was actually reported. Prevalence was reported to be higher among sex workers, fisher folk, and men who have sex with men. And as we can see, for the sex workers, commercial sex workers, it is up to 35%, fisher folk 23%, and our discussion in the morning of, actually mid-morning, of actually saying the key, actually the key, is being reflected here. And approximately 1 in 4 new infections occur among key and vulnerable populations. Next. At HF Uganda Cares, we conducted a retrospective study among key and vulnerable populations that tested under the facilities that we are supporting under our testing program. And we analyzed data for clients who tested between January and December 2022, and those were the clients who tested and were 15 years and above are the ones whose data was analyzed, and we are here to present. And we tried to characterize within the wider key populations what is the specific subgroup that is more at high risk and that is presenting with more prevalences. You know, when you're talking about key and vulnerable, it seems a bit bigger and we may not get the picture. So we tried to scale it down, and we looked at the different subgroups within the key and vulnerable populations. Among them, we looked at people who inject drugs, partners of people who are back a bit, partners of those who are HIV positive, and adolescents and young women. So the total tests that we conducted in the year 2022, we tested 310. So we tested 310, 890 clients in the reference period of 1 year. And out of that, 69% were females, and 25% of those who tested were from the key and vulnerable populations. So overall, among the key and vulnerable populations, HIV prevalence was 3.5, and it was high among women and older persons. It was high among older persons. And then, what were our findings? Our findings, when we stratified by key and vulnerable population subgroups, we found 11% prevalence among previously negative sexual partners of people living with HIV. We had testimonies here in the morning where people have lived with positive partners, but they are not seroconverting. But in our study, we found that we are seeing more people actually seroconverting. They were previously negative, but staying with a positive partner. Also, prevalence was 6.9. And then, among those who use drugs, prevalence was 3.9. And that was just a breakdown. Let us go to the next slide. Yes. So we tried to make sense of the data. And what you are seeing there in blue, the blue bars, the subgroups within the key and priority populations. And that red curve that we are seeing is actually telling us the positivity among the different subgroups. And as we are seeing, the curve goes down and goes up. It peaks around subpopulation 3, which is prisoners and people in temporary detentions. And also at the extreme end, where we have partners of people living with HIV. These partners were previously negative, but in the subsequent year, they became positive. So we are seeing an increase, as we are seeing in the curve, of going up, meaning we really need to have an intervention there. Within the key populations, we need to focus on partners of people who are living with HIV, who are negative. Risk among the subpopulations, we tried to look at the different risks within the subpopulations of key and vulnerable populations. And the negative partners of sexual partners living with HIV were 2 times more likely to get HIV compared to sexual partners of general key populations. So within the basket of key populations, we compared those who are living with a partner who is positive and generally the partners of KP. And we found those who are living with HIV, partners living with HIV were 2 times more. Also, those using drugs were relatively more than those who were injecting drugs. And the detainees were also slightly more than those who were compared for mobile populations. Next. So in conclusion, we are saying that we are seeing quite a number of previously negative partners living with people who are positive, seroconverting in a period of time. So we need to, there is an indication that maybe there is less combination prevention that is being utilized. And our recommendations are we need to scale up access to differentiated combination HIV prevention services for key and vulnerable populations. Then we need to targeted scale up of cutting-edge biomedical interventions, such as PrEP, for HIV-negative partners, that reduce on the infections that are occurring. And then there's need for more inquiry in the validity. You know, we have read about it. It has been published widely of the concept of undetectable equals untransmissible. Given that we are seeing partners who were previously negative and transmit, so there is no other use of any prevention or intervention. So there is need for more research on that, and that is what we found out. Thank you so much.
Thank you. I think there are questions there. That finding was a very important finding because we are challenged with you equals you in our context. Thank you for the study. Dr. Kadama.
Yes. By the name's Dr. Herbert Kadama, working with the Ministry of Health and coordinating the PrEP program. I will be taking you through the multi-choice mix for HIV prevention and why we are looking at people having different choices for sent them to the Secretariat. Yeah. So I will be talking about expanding the PrEP options and access for women. That is creating policies and piloting the PrEP ring and the Kabla PrEP in Uganda. So briefly, I wanted to go through the journey of PrEP in this country. We initiated oral PrEP in December 2016. That's when we came up with a policy to guide the implementation of PrEP. But actual implementation started in July 2017 with 6 sites. We are scaling up PrEP through a phased funded approach, and the modes of implementation are both facility-based and community-based approaches. So as I talk now, we are in 15 regions out of the 16 health regions of the country, and we cover 65 districts, and we are in 587 health facilities across the country. And over 400,000 clients have ever been initiated on PrEP by the last quarter. So I will be talking about the rationale, progress, and plans for introducing the new PrEP products, that is the ring. Methods have challenges, and the challenges we are having are mainly low uptake and also low persistence. And this one is a result partly of lack of discrete products that are under the control of the user. And we know very well that there is no single product which can solve and be, which can solve all the user's needs at the different life cycle, especially of a female. You know, the female has a different reproductive health cycle. It goes through pregnancy, it goes through breastfeeding, and there are moments when she is neither breastfeeding or pregnant. So women particularly need to prevent HIV, as I've said, in the different reproductive phases, using either daily, monthly, or slightly longer choices, and both choices which are either local or systemic in nature. Next slide. So now I'm moving to the different choices we are introducing. I will start by the event-driven PrEP. This is mainly for men, or those assigned male at birth, and that is what we talk about, the 2-1-1, 2 pills, 2 hours to 24 hours before the sexual event, followed by 1 pill, 24 hours after the first 2 pills, and then followed by 1 pill to 48 hours after the last pill. So we, as a country, we have started giving event-driven PrEP. We went to Eswatini, which has a very promising PrEP, ED PrEP implementation. And when we came back, we managed to incorporate ED PrEP into our technical guidelines, and we also developed ED implementation guidelines to guide the implementation of PrEP in the country. So we reviewed and updated our training curricula to include ED PrEP, and now as I talk, we have had a national TOT, training of trainers on ED PrEP, and we what we call pilot facilities. And in these pilot facilities, we are having intensive supervision and mentorships so that they guide us on how we can scale up PrEP after here, after learning issues to do with the acceptability and feasibility of ED PrEP. But as I talk now, since we have weekly meetings, the results are promising. And we are planning to roll out ED PrEP beginning in January into all other regions of the country. Currently, we are using the facility-based mode, but as we continue, we shall also start giving out ED PrEP through the community-based approaches. The other method we are rolling out is the dapivirine vaginal ring, or sometimes we call it the PrEP ring. The PrEP ring, as you can see in that picture, is a flexible silicone vaginal ring, and in the vaginal mucosa when it is inserted in the vagina. And this is a woman-initiated method. They can do self-insertion or assisted, usually when they are beginning. It is discreet, but most of all, from all the researches which have been done, it does not interfere with the sex. And it is long-acting. It takes 28 days when it is inserted in the vaginal mucosa, and it is stored at room temperature, so we don't have any worries about cold chain. Next slide. So the ring has already been approved by NDA. That was way back in October 2021. And we have also included it already into our technical guidelines and even in our HMIS tools. Currently, we are carrying out demonstration projects in 7 sites under the Catalyst study, which is under USAID Mosaic project, to find out issues to do with the acceptability, feasibility, what are the barriers and enablers of uptake of the ring. And when we complete this, we hope to do a phased rollout nationally, and this rollout will be guided by the PrEP targets we are developing using a tool which is called PrEP-IT. And I want to say that under the Global Fund, the ring for 30,000 individuals by the year 2026. Next slide. So the other one is the carb PrEP, which is also called the injection. And this one is also used in preventing HIV, especially among the high-risk populations. And it is an injection given in the buttock, followed by month 3 or after every 2 months thereafter. And it takes about 1 week to be effective. And here we expect that a person using this injection should be using another method within this 1 week, so long as to get protected against HIV. A drug which remains the carb in his body for around 1 year. This one is not enough to protect this individual against HIV, but why we call it a tail, but our fear is that somebody, if he gets infected, he can easily get resistance to the cabotegravir. And we know that DTG is one of the drugs within that, and we don't want to have that. So if someone is still at risk, this is a period where we expect them to be using another HIV prevention method, which he accepts and is cancelled on. So this one, the injection has not yet been approved by NDA, but once done, we shall have also demonstration projects within the 7 sites under the Mosaic project. Next slide. The other thing we are doing is introducing PrEP in the private pharmacies. So here, we have already developed a concept note, and it has already been discussed with the technical working group. The pharmacies have been assessed, and we are riding on these pharmacies which are already providing ART for those who are HIV positive in the private pharmacies. They are the ones we are riding on. And currently, we are developing guidelines on how this public-private partnership will flow out, provide PrEP within the private pharmacies. As I end, I just want people to know that we have a number of researches going on in the country on PrEP. I had already said we have the implementation study on the PrEP ring and the injection PrEP by Mosaic. We have the 6-month injection, which is being studied under Mujo in a number of facilities, Chivoga being one of them. So we have also a study which is being done by IDI, especially for PrEP in those people who injected drugs. And Makerere University School of Public Health is evaluating the PrEP delivery models, that is facility vis-a-vis the community. And also there is a study which we are doing, which I think I will be presenting tomorrow, the results on PrEP uptake and continuity, which was a quality improvement collaborative between the Ministry of Health, UHA, and the METS. So, what are the priorities as a country? Beginning next year, we want to roll out the vaginal ring. I had alluded to 30,000 by 2026. We want to use virtual platforms to increase PrEP uptake and continuity. I want to tell people that we have what we call Uganda PrEP app, which can be downloaded by those who have the Android operating system of the phone. It's not yet on the Apple, but it guides people where there is PrEP, common questions, adherence issues. It has a lot of information. It can be downloaded from the Google app. Then we are going to scale up PrEP, both geographically and in the subpopulations, especially the pregnant and breastfeeding, where we are seeing a lot of new infections and the AGYWs. And we hope that we want to move from the 587 facilities to the 1,500 facilities in the 145 districts by the year 2026. We're also looking at strengthening the community and private-public partnerships, and especially, I've said, provision of PrEP in the private sector, and strengthening the PrEP communication strategies. For partners, South-to-South learning network, then implementing partners, DHTs, health facilities, and health workers. And lastly, but not least, CSOs, CBOs, peers, and the end users. Thank you.
So thank you, our panelists. Good afternoon, colleagues. We are sorry for keeping you hungry, but we thank you for your indulgence. And we welcome our partners who joined us while we were already in the session, including partners from the UN family. I've seen paper partners and all implementing partners. So it's time for questions. I know you're hungry, but we have just received 4 presentations, 2 which were basically about program rollout. One about PrEP by Dr. Kadama, and the other about the rollout of a shangring, a circumcision strategy approach by Henry Karunji from Beira, and 2 presentations about populations, transport workers in Imbarara by the gentleman from Bishop Stewart University. I want to congratulate you among the young people who have made clear presentations today. So he studied transport workers, border, taxi drivers, and truck drivers in Imbarara, and what influences their uptake of multiple prevention services, and discovered that most of the services they took up were mainly condoms, but he articulated the other factors that determine those who take up more than a condom or more than the services. And the other presentation, of course, was about seroconversion, which introduced something that is good for a discussion, which has an implication, because right now, we are considering as a country, we are reviewing our national policy, and the key on our agenda is to adopt the U equals U strategy. But you notice that in his submission, he appears to conclude that we need to think again before we adopt the U equals U strategy for our setting, because he studied seroconversion, the rate seroconversion among partners of key populations and people living with HIV. And he documented significant seroconversion rates that caused him to conclude that we need to rethink U equals U as a main conclusion. But of course, he made several recommendations, and I want at this juncture to invite the audience. I see the MC already pointing at me that he has given me 10 minutes. So let's have your questions answered. So by show of hands, who has the microphone? Please, move the mic. Let's see, are we letting the panelists tell us how they interpreted their results? So by show of hands, I will accept the first 4 questions, and I will not go beyond 4 questions because of time. The question I wanted, okay.
Thank you so much. I'm Amy Mulumba from Moju. We know PrEP is effective. Since we want to start continue preventing HIV, I want to ask the previous speaker, what strategies do you have to rule out rumors from the communities? Because we know people don't know much about PrEP, and since also Kabla is new, we want to find ways of stopping rumors, because it's not easy to start something when you're not aware about it.
Thank you very much. Next question.
Thank you so much. Ms. Kababilio team from Muju. My question goes to the previous speaker. We just had a study called Insight. End of the study, most of them, okay, we try to link them to care, but most of the girls either didn't go or went and stopped along the way. What's your comment on that? Thank you.
Okay, thank you very much. Jennifer is my name. Okay, one, I would like to comment on the gentleman who spoke about the U equals U thing, that concept. Clearly, we can see that our government for prevention. However, concerning your data, I feel like it's kind of a little bit not sufficient. Not really sure whether these people who turned, who seroconverted, the issue was actually because they did not involve with other kind of people who maybe had a high viremia, something like that. Yeah? So to me, I think that before we even rethink about it, there's need for more research under your study. That is one. Number two, it goes to the gentleman of PrEP. Yeah? So here, we are thinking of bringing up or coming up with the cabotegravir long-acting cabotegravir as the PrEP. Yeah? However, have we really researched about it that even when because currently we are seeing people failing on the DTG-based regimen. So when we use it, we go ahead and use it on people who are engaging with people that are failing on the DTG. Will it still work? That is my other question. Thank you.
So, okay, I think you asked a very good question. If I had the authority, I would ask the people to clap for you. The question is, the conclusion that U equals U may not be okay. Did you prove that actually the new infections, the seroconversion was because of their partners? That would be key. Before we say we cannot, the question from Mulumba and Babirie to Dr. Kadama, the first one is strategies. You have to stop the rumors, the misconceptions, failed linkages, and the other questions from Jennifer, I think, are directed to you. So you can have the floor. You don't even have to come here in less than 3 minutes.
And the meeting actually, what? low. And therefore, we expect your partner who is negative to actually remain being negative over time. But if, again, studies actually, our findings are showing us otherwise, that again, we are seeing more partners of people who on treatment seroconverting. There is need for more studies. So this is not a conclusive study, but it is just a pointer that we need maybe to look in that direction. Are we not doing something right somewhere? Are our negative partners not doing right? Or our positive partners not doing right? So it is something that we need to dig deep and find out. But that is what we found out, and we had to share, because it was also, to us, we looked at it as unique in its own way, given that we know from all the publications that U equals U. But if, again, more partners are getting infected, who were previously negative and staying with positive partners who on treatment, it brings questions. So, Chair, I actually don't want to say I'm concluding on that, but it is something we need to take up. Thank you.
Yes, the myth and misconceptions. Well, as a ministry, we have the PrEP communication strategy and framework. So this one guides on how to communicate about PrEP, through communication about PrEP, and it is currently, as you expressed, undergoing review and revision to include the injectable PrEP and issues to do with the ED PrEP and the PrEP ring. So it's from that we shall develop materials and messages that will go out to the community to dispel those myths and misconceptions. And also riding on the community strategy, which addresses client literacy. We shall use also, that's one of the strategies. Then the other thing, you will say you are doing a study and you are linking the AGYW, why they are not reaching. Because for now, I think the strategy will be to find out why the AGYW are not reaching the facilities. What are their concerns? Lastly, your expression about the carpetographer, I think this one has been researched and recommended by WHO for use as a prevention. And if it is used correctly, we shall not get issues to do with the resistance. And that's why we are running, first of all, the demonstration projects under the Mosaic project, which will guide us on how to fully implement Kabla or injectable PrEP into the country. Thank you.
So thank you, panelists. You can clap for our panelists, please. I want to hand over to the substantive chair of the session to summarize the session for us, and in 5 minutes we should quit.
Thank you, colleagues, for persevering in this hot afternoon and staying till the end of the session. We have had very good presentations, papers, and also programmatic issues discussed this afternoon. Thank you so much to the presenters, and thank you so much to the audience, those who ask questions. This is accountability. This is pausing to see where we want to go as a country. So specifically for this session, and please, there is a follow-on session tomorrow on HIV prevention. Among the key, we said key, the key, door key. If you don't open the room, the door where those key people are, there is no end to HIV/AIDS. So please get interested in attending these sessions where issues of HIV, ending HIV by 2030 are discussed. So in those 6 papers, things that came out are the highlights. Maybe I start from the last one, where it was about PrEP programming from Harvard, discuss how the ministry is positioning and the country is positioning to roll out PrEP. And clearly it was noted that not only PrEP, but all the interventions for prevention are suboptimally rolled out in the country. Can imagine for PrEP, we are not yet there. We are only in something like 600 sites of the 1,500 sites that we want to go to. We have districts at the moment. Are they in Uganda under your program, sir? They are not yet under the program of Herbert on PrEP programming. So, and that is only for PrEP, but all interventions are still suboptimal. That's something to take home about. We have, and that is for oral PrEP, but the new interventions like ED PrEP, DVR, and Cabel A, to some extent, even these so well-proven interventions globally are not yet approved by NDA. We also had a paper in the morning presented by somebody from, I think, Namayingo, where HIV self-testing went down and people asked questions, how come? Clearly, it was explained that there is a shortage of HIV self-testing kits in the country. This is well known. I know discussions are going. Research is really still important to find the best models, to find the best interventions to end HIV/AIDS. Issues that are holding us behind: knowledge, stigma, social behavioral factors came out prominently in the presentation. Not only that, among the communities, but even the health workers. For example, we had they didn't know how to use HIV self-testing kits, and this attracts a lot of capacity building among the health workers. We are not yet there, and this is only in the 45 districts we have reached. What about the 145 districts? There's a lot to do. Scope and geography is limited. I've mentioned that, and continuous research needed. And the close of this class from the Minister of Health. Thank you. Maybe an announcement is that we are supposed to go for a brief lunch session, and we'll be connecting with the main session, which will be here in this room starting shortly. It will entail the opening ceremony where we shall have the dignitaries recognized, and also we shall have the ministers, government officers, and colleagues from civil society and the donors. So we are requesting you, if you're going for a break in time, slightly on time. Thank you.
Hello, hello. Good afternoon once again, friends. I request that we reconvene and start the afternoon program. As I indicated earlier, we have an elaborate lineup of presentations, and it's only fitting that we start. As you will realize, we are expecting the guest of honor, we are all and some other partners to join us. They are on their way, and we will be adjusting our program accordingly as we move forward. Allow me stand on the protocol as already lined up earlier, but permit me to recognize the presence of a few persons who joined us as we were having the breakaway sessions. We have been joined by the DOD Country Director, Dr. Vamsi Vasredi, waving at us. Thank you very much. We also have amidst us the PCOPS Country Director, Ms. Lily Asraf, right there. We also have the PEPFAR Country Coordinator, Ms. Mary Bagman. You're most welcome. We have a number of Peace Corps staff and volunteers. You may wave to the rest of the participants here so that they can see you as well. I'm going to request my co-MC, Winfred, to shortly come and recognize the elaborate list of exhibitors who are exhibiting their different products and services involved in the fight against HIV/AIDS. I want to also recognize the AIDS Commission, the representative of the Executive Director. Dr. Vincent, kindly stand up for recognition. And many of you who have found it important to be here. Winnie, please come forward and Winnie, who are exhibiting. It's important that we take note of the different products that are being exhibited by the various partners.
Thank you so much. Before I recognize the partners in the HIV response, allow me in a special way recognize the presence of and she'll be chairing the afternoon session. Ladies and gentlemen, once more, allow me to recognize partners and civil society organizations that have been supporting the HIV response, and they've also been able to showcase some of their work. I think you've been touring the different exhibition stalls and tents. So we have TASO. TASO is a center of excellence in HIV care and treatment. In fact, TASO was the first organization to come up with interventions supporting community psychosocial support programs, and then scaled up to treatment, and here we are. So we want to thank TASO so much for supporting the HIV response. We also have Uganda Cares. Uganda Cares provides care and treatment programs. both in the central region and across the country. We thank Uganda Cares so much. We also have Moju. Moju is Makerere University. Moju is joint, it's in Makerere University Joint Health Program. Moju undertakes research in the country. And then we have Makerere University Walter Reed Program, also supporting with HIV prevention, care and treatment research. And of recent, they are going to start the HIV cure research program called HOPE. So we hope that we shall have an HIV cure someday. We have Baylor, Uganda, and we have Baylor, Uganda, and Makerere University School of Public Health Program. It is not only an academic institution, but also undertakes research. So we recognize Makerere University School of Public Health. And we have an Tindieva, who was response. And aside of HIV prevention, we have civil society organizations that support advocacy programs in the country. I saw Kitgum district here. I was also able to see a rural network of people living with HIV. And we had Dr. Wachiti Stephen, who chairs the National PLHIV Forum at national level. And we have a board member from Nafofanu here, Ms. Jane Mirimuvi. You're most welcome. I also want to recognize the Armed Forces, UPDF, right behind there. We thank you so much for honoring our invitation. And then we also have IDI. The IDI team is showcasing right behind you. And we have St. Francis Hospital, and then the private sector. We have NSSF on board. We have the media fraternity, and also the self-coordinating entity. And then we do also have students, the Uganda National Students Association, because we believe in working with young people. We have UNASO also on board, among others, quite a lot of partners. We have also the fellowship on TB partnership and the Stop TB partnership, among others. Thank you so much. And lastly, I would also love to inform you that we have a community village just opposite this tent. So anything to do with structural interventions has been happening right in the other tent. And it is done in such a special way that we are using drama, we are using poetry, singing and dancing to create awareness on HIV prevention. So feel free to also join the other tent. Thank you so much. I would love to welcome my MC, the main MC. Oh, right behind me. Yeah. I was looking for you.
Before I invite the chair of this afternoon's session, we are going to have a drama skit as part of the edutainment by the Legends. Is the Legends group here? The Legends that are supposed to perform this afternoon? The Legends, are they here? If the Legends are not here yet, I think if the Legends are not here yet, allow me now to take this opportunity to invite Honorable Ayebare Margaret Rwevyambo, MP from Mbarara District, who is going to chair this afternoon session. As I was briefed, been any of the discussions on HIV/AIDS says that Mbarara District is now the young site of the new you had anticipated.
As they have already told you, my name is Ayebare Margaret Rwevyambo. And most importantly, I sit on the HIV and AIDS Committee of Parliament and I'm glad to be here and to take up the chair in this afternoon. I want to take this opportunity to thank every one of you who are here to participate in this HIV and AIDS symposium. I don't know whether it would be right for what he has said that I'm chanced to be here after Mbarara has been spot on having the highest HIV prevalence of the rural area in this country. As I've told you that I sit on HIV/AIDS Committee of Parliament, when I reached Parliament, I chose to sit on that committee as a standing committee, and I also sit on Health Committee as a sectoral committee because of the background that I had before I joined politics. I worked with the Ministry of Health, specifically Mulago Hospital at the National STI Control Unit, with key populations programs. And I saw a lot to do with HIV programs. And when I joined Parliament, I had that background and that, interest in sitting on these committees to ensure that one or two things can be done for the people living with HIV, and also forge ways and strategies of how we can end HIV in this country. So today I feel so honored to be here and to chair a session in this afternoon program. Mbarara, as they have said, when I hear that it has the highest HIV prevalence, it brings me back to what responsibility do I have in ending HIV in this country. And as I've already said, a reason in this country, or how I can contribute to ending HIV in this country. I want to bring this to your attention. Mbarara District and Mbarara City. Mbarara City's HIV prevalence is 8.1, and Mbarara District is 14.4. So you can imagine when a rural area's prevalence becomes higher than the city prevalence, it becomes worrying, especially to me as a leader who is a member of Parliament, and especially when it is like the more HIV is in young women, of which women are the ones that I represent. So I want to request all of you to give me support here that I used to work with when I was still there. I know you're not going to leave me alone. We have to forge ways and means and strategies on how to end HIV, beginning with Mbarara. Kindly, the developing partners that are here, I think you need to work with me and see how best we can end HIV, beginning with Mbarara, though it is targeting the whole country. We are still waiting for the guest of honor, as we are all aware, but we all know that time is not going to wait for all of us. So I want to take this opportunity to invite the keynote speaker of this afternoon, who is going to tell us about ending the HIV vulnerability dilemma among adolescent girls and young women, and what we need to do better. NFPA Country Representative, Daniel Alem. Let's join hands to welcome I've been informed that the next presenter who is going to give us keynote speech, like two minutes. So I think we can wait for the 2 minutes as he comes in to give us the keynote address on what do we need to do better than what we've been doing to end HIV, especially in the vulnerable groups. Opportunity to welcome the U.S. Ambassador to Uganda, His Excellency William Dopp. You're welcome, Your Excellency, to this meeting, and we are glad to have you here this afternoon. So as we continue to wait for the next speaker, I want to say that one of the events of this symposium is looking at those people who were here before us that moved the journey of HIV and AIDS. And what do we learn from them? We all know that we are commemorating one of the great men in this country by the names of Philip Bongere Lutaya, who came out to speak about HIV and AIDS. Despite the stigma that comes with HIV and AIDS, despite the discrimination that comes with it, this gentleman, may his soul rest in eternal peace, came out boldly and said that he was in him. What do we learn from him? What do we learn from the exposure? What do we learn from disclosing that you have HIV? As we look for different ways to end HIV in this country, what do you and me learn from Philip Bongere Lutaya? As young people, because I remember when you're reading what he left behind, he had messages for young people, and I'm being informed that there are young people in this tent from different universities. My question to you, or my message to you, is what do we learn from Philip Bongere Lutaya's message? Do we still abstain as he really told us before he went to live another life? His two messages were abstinence, if you can. His message was, if you have not contracted HIV, how do you continue to live without it? And his second message was, how do you take your drugs religiously, that even when you have the virus with you, you can still live and maybe achieve what you thought you'd achieve in this world. So as we go on, I want us as young people to reflect on this Philip Lutaya's presenter as we wait for the UNFPA country representative who is supposed to give us the keynote address. And at this time, I'm going to invite a statement representing the people living with HIV and AIDS. Raymond. Another hand of applause as we welcome Raymond to give us a statement representing the people living with HIV and AIDS. I thank you.
Thank you very much, moderator. Our distinguished guests, protocol observed. Greetings from Nafafando and the PLHIV constituency. This is a statement by the people living with HIV presented on this day. As a constituency of people living with HIV, we are delighted to be part of the National HIV and AIDS Symposium, where we have gathered to take stock as we move the last mile towards epidemic control by 2030. We are very grateful to the government of Uganda for the support rendered, our donors and the development partners, to over 1.4 million people living with HIV, that our lives have been impacted positively and our quality of life has greatly improved. This year's symposium theme of my responsibility towards ending AIDS by 2030 reminds us of a joint commitment and collective efforts towards a common enemy. It is at this point that we reflect on the milestones in achieving the 95-95 targets, which guide us in reaching the epidemic control. We have done well in the second 95, where access to life-saving antiretrovirals has been possible. However, if and cost such as disclosure at workplaces, treatment literacy levels still remain very low, intermittent stockout of drugs and commodities for HIV and TB, the fear that the donors may pull out of funding HIV treatment, leading to many of us to die as domestic funding has remained low and the AIDS Trust Fund unoperationalized since 2014. Besides, stigma remains a structural barrier. Prevention efforts, socio-economic programs do not target people living with HIV as a special category, and our children, adolescents, and young people require special programs as viral load suppression has remained low among these age categories. It is at this point that I would like to applaud Uganda AIDS Commission for the development and dissemination of the stigma and discrimination policy guidelines. We really appreciate it. Thank you very much. However, it also shocks us to read in papers, like for most of you who read the Monitor of the 10th this month. If you can search for it, it is unacceptable during this time. It is against this background that, as a community of people living with HIV, we would like to propose a number of interventions as each takes responsibility to end AIDS by 2030. Increase domestic funding, operationalize the AIDS Trust Fund and the health insurance. We really appreciate the programs and the plans. However, if these can be operationalized, the better. Have an enabling legal environment that supports community members to freely and open up and participate in the HIV response. The laws that criminalize HIV communities, such as the KEPIs, will be counterproductive. Nationwide rollout of treatment literacy among the people living with HIV. Each must understand the disease being managed, the do's and the don'ts, if we are to have continuity in care and viral load suppression. Implementation and monitoring of the HIV stigma and discrimination policy guidelines up to the lowest level, using various various ways of involving multi-sectoral players. And besides, stigma reduction interventions must be specifically funded based on what has worked with minimal resources. We really call upon Uganda AIDS Commission to leverage on the communities of people living with HIV who are the stigma and of people living with HIV in planning, implementation, and monitoring of all programs pertaining the lives of people living with HIV in the spirit of nothing for us without us. Let us work with people living with HIV leaders at community, subnational, and national levels. Mitigate stockout of drugs and essential commodities, not only for HIV, but also comorbidities, and integration of services is the way to go. Need support to strengthen our PLHIV structures at all levels, national, district, sub-county structures should be engaged or strengthened. We are grateful to Uganda AIDS Commission for the opportunity provided to people living with HIV, and we believe that working together, we shall end AIDS by 2030 as a public health threat. We call upon development partners and agencies to fully support our government in this noble cause for the betterment of our lives. As a community, we are ready to take the mantle and work with all of you.
Thank you so much, Raymond, for that presentation or statement from the people living with HIV. Nothing for us without us. A meaningful representation. How I wish everyone would know that there is no person who can tell a story better than the person that has experience of that very story. So when people living with HIV and AIDS come here and give a statement, we need to pick from what they've told us, and as we program and strategize, we know how to work with them. So me and you, our responsibility is we need to ensure that we do not add on the population of the people living with HIV. How we are going to do it is the reason why we are here, to listen from different people and forge a way out together. At this moment, I want Mr. Bill Clinton Nasasira to come and give a statement by young people as our UNFPA country representative prepares to come next. Mr. Nasasira is in the house. Is being represented by another young person. I was calling a gentleman and I'm seeing a lady coming in. That's why I was asking whether he's in the house. But you're welcome. Please take the mic and give your statement.
Thank you so much. Mr. Bill Clinton Nasasira, the president of Uganda National Students Association, is in Gulu, interacting with guild leaders and other student leaders at the Pan-African Symposium that is at Gulu University. That is why yours faithfully, the speaker, is here to deliver as said. I will stand on the agenda as earlier on aligned. My name is Chiyuba Jenna. I am a fourth-year student of Women Affairs at Uganda National Students Association, and by the grace of God, I am serving as the speaker currently. Uganda National Students Association is an umbrella that advocates primary by the Ministry of Education and the National Council for Higher Education, respectively. We take this opportunity to thank the Office of the President and the Government of Uganda for supporting Uganda National Students Association since 1988, when it was recognized as Uganda National Students Association from former National Unity for Students. The government of Uganda setting up the Uganda AIDS Commission has been very important to us, the students, because Uganda AIDS Commission to make it look better, you know, and shorter. Exactly. So we want to thank Uganda AIDS Commission for always supporting us. We know that they have our back every time. We have engaged in debates with students, and this year we had a debate that we had over 128 schools engaging in a debate tournament with 5 representatives from each school. So what we are doing the most is advocacy and expanding awareness. So, and that we were very much supported by the Uganda AIDS Commission through funding, through giving us material and other resources. And I want to thank the director for making it happen. Sharing information selflessly about HIV/AIDS is what is going to help us as the youth, as the parents of tomorrow and the parents of now, so that we can curb this and achieve the vision of 2030 of curbing new infections, having 0 mother-child transmissions, those are the new infections, having 0 stigma among us on non-discrimination, and also having 0 AIDS-related deaths, because those are the main things we are really looking forward, and we only have 7 years. Ladies and gentlemen, we each have, so I call upon the mothers affected by what your relationship was before they were brought to this world, because we are seeing a lot of children are coming into the world and they're already infected, yet we can curb that, and so we can prevent new infections. My message specifically is to mainly the youths to get informed, get information about AIDS, because you know we always get shocked every single time we interact with Uganda AIDS Commission. There is something new that we learn as students, like it's another device for women. Then they talked about the injection. So I mean, there is need for us, the youths, to go an extra mile of learning what other options do we have other than condom use. Because I mean, condoms mostly are being set as a main issue because female condoms are really expensive and we don't have them at universities, yet people are sexually active even when we advocate for abstinence. So, but then we have other options. So I think the youths, we need to learn more about other options, maybe other than condom use, and the importance of having our lives. And for my female that I represent at the students level, I just pray that we learn how to work hard so we do not just get distracted by simple things that can cost us our lives. And also to use protection, we practice safe sex. We get tested to know our status so that we can try to keep record on whatever is happening right now. To also break the stigma, do not stigmatize someone, because I mean, AIDS is not the end of life, you know. People have lived with AIDS. We have Dr. Watiti, I don't know if he's still around, Professor Watiti. He has been speaking to a lot of youths, and he has not died yet, he has lived for many years. So I mean, why are you stigmatizing someone? They might even actually become your bosses, you know? And then you just made them feel less of themselves. So to also spread awareness, and that's what Uganda National Students Association is doing. I also implore the youths to draw a line between recklessness and courage. We have taken this everything to just be trying out everything, and we are calling it courage, yet it's being reckless on our lives. So the men and the women, especially the youths, let us draw a line between recklessness and courage. They are way different, but then we are carrying them as if they are the same things, and we are not caring about what the future has for us and what these statistics mean to us as a country. I also look at religious and cultural leaders. You know, when we look at Mbara statistics, Mbara district is the rural part of Mbara. which means maybe we would not be getting those issues, but you know, the government and operational bodies that are looking at AIDS response are more concentrated in the town areas because that's where most population is. However, we are neglecting the villages, and since us, the religious leaders and cultural leaders are there in the villages, how about we take it upon ourselves to be talking about AIDS in church regularly? I mean, it's not a big deal to just create a session after church and you just talk about the youths, their relationship with AIDS and relationship with each other. I believe that would be very significant to us. The Uganda National Students Association also recommends Uganda AIDS Commission to increase the information they put out for us in public. For example, now it was very much known that Mbarara has an over 14% prevalence at this point. But then we have not gotten something from Uganda AIDS Commission telling us that it is okay, they are there, but then we can reduce the new infections that are supposed to be coming in. So, and then just to recognize the fact that currently social media is it's too much spread, and there is need for us to utilize social media to just make youths, the ones that are infected and those that are not infected, to just be aware of what is happening, to give us hope. I mean, how about such a message like AIDS is not the end of life, signed by Uganda AIDS Commission, and it's out there? Because there are many memes moving around. Just, for example, there are memes that threaten us to go and check. Talking about AIDS just today on all of us, our social media accounts. I mean, you know, it could create a difference because some other person is just looking at your media and following you and seeing what you are doing. For us that are infected, we need not to aggravate the situation by spreading. Let us take caution. Maybe if the doctors tell you that you take your medicine on time, kindly adhere to that. Let's take the medication on time. Let's do any other preventions that we can so that we don't spread it to the next person, and also look at the next generation that is coming. Together we can achieve the vision, the presidential initiative of 2030 of zero new infections, zero stigma and discrimination, and also zero AIDS-related cases. For God and my country, we stand for liberation as the Uganda National Students Association. Thank you.
Another round of applause for Jemima, who has represented well her president. We want to thank you, young people. Messaging. Uganda AIDS Commission, you're the custodians of messages of HIV and AIDS in this country. As a person, even before I joined politics, even before I went to the other side of government, I used to talk about the messages that go out when it comes to HIV and AIDS. So the young person has echoed on it. For example, AIDS is not the end of life as a message out there so that it can reduce on the stigma. People get to know that even when you have HIV, you can still live. You can still achieve your goals. You can still be of hope and use in this country. There is one time when I was still working with one of the NGOs of key populations in this country, and we used to find messages. And one of the messages that used to disturb my head and conscience, sex workers in this country who give in sex for money. And I would be like, if this message is being taken up by a sex worker, how is it going down with this person? Don't give in sex for money, yet there is someone who is selling sex. Messaging, Uganda AIDS Commission, there is a lot to do if we are to put our hands together to fight HIV in this country. And I will take this opportunity to welcome her as she comes in and to give you a brief of how the program is going to continue once she gets in, after she has been ushered in and given her seat. we will all welcome her and raise up for the national anthems, both Ugandan anthem, East African anthem, and then the HIV/AIDS anthem by Fancy. She is being briefed by the directors at Uganda AIDS Commission. But as she comes in, I also want to continue reflecting on what the youth has talked about. Honorable Minister, you're welcome. I think we can all raise to welcome her as she's being ushered in. Honorable Minister of Presidency, you're welcome. I want to take this opportunity to welcome you to this second National HIV and AIDS Symposium that is taking place here. You're welcome. My Honorable Minister, you're welcome.
Thank you, dear.
We shall all keep standing, and I would request the DJ to pray anthems in the ascending order.
Out there somewhere, alone I'm frightened. Oh, the darkness, the days are long. Life in hiding, now I'm making you contact. No more loving arms, fall around my neck.
Take my hand now, I'm tired of lonely. Give me love, give me hope. Don't desert me, don't reject me. All I need is love and understanding.
Today is me, tomorrow's someone else. It's me and you, we got us love our fight. We share a light in the fight against AIDS. Let's come on out, let's come together, fight AIDS. In times of joy, in times of sorrow, let's take a stand and fight until the end. With open hearts, let's stand up and speak out to the world. We'll send some light, save the children of the world.
Thank you so much. We can remain standing and we have a word of prayer.
Bismillah. Let's humble and pray. أعوذ بالله من الشيطان الرجيم إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر. Amen.
Thank you so much once again. Come. You found us in the middle of the afternoon session, and we are glad to have you here. And I want to take this opportunity to introduce some of the people that we have with us here. We also have the Peace Corps Country Director, Miss Lily. PEPFAR Country Coordinator, Miss Mary. Peace Corps staff and volunteers who are here. We also have Dr. Dennis Bwanika, U.S. Mission. We have Ministry of Health officials. Ministry of Health officials who are here. Even when you don't stand up, you can raise your arms so that the minister get to know the ministry officials that are here. In this house, especially those. We have people from private sector. We have people from the network of people living with HIV and AIDS. We also have people from research institutions. You're welcome. For those that I have not introduced, maybe have not gotten your names here as we go on, I will continue to introduce you. Honorable Minister, without wasting any moment, I'm going to invite Dr. Bagambe Vincent, who is going to give key highlights from GAR report.
Thank you very much. The Master of Ceremonies, Honorable Margaret Rwebyambu, who is also a member of the Parliamentary HIV Committee, HIV and other social-related affairs. Minister Mire Babiria Babalanda, Minister in charge for the presidency, His Excellency the Ambassador of the United States, the chairperson of the AIDS Development Partners Group, and beyond that, ladies and gentlemen, allow me to stand on the protocol that our dear session chair has established and brief. You are all most welcome, and thank you for coming to this session. Honorable Minister, before you came in, we have received two presentations which were relating to this closing session. We had a presentation from a representative of the persons living with HIV and AIDS who appreciated the services that the government is offering to them, but also requested that we should eliminate all the barriers to accessibility to services to make sure that all people living with HIV and AIDS access services as one way of taking us close to ending AIDS by 2030. As we were entering, Honorable Minister, we also received a present, gave us the opening prayer. And for the young people again, they appreciated Uganda AIDS Commission's engagement with them. We've been engaging them, Honorable Minister, in organizing debates through which they are able to sensitize and advocate for HIV prevention amongst their friends. I think the challenge she raised was how we can address the area and be able to take HIV prevention messages to the young people in a modern way. I will now give a few highlights of the report that we have presented at today's symposium. Honorable Minister, Honorable His Excellency the Ambassador, and dear friends, we have discussed this report, used highlights of the report, but also we had a panel discussion here by different, including we were honored, Honorable Minister, to have first physician, the first doctor in Rakai to identify HIV/AIDS patients in 1982. He was here also to share his experience. So in this report, we are noting that there is overall a decline in the incidence, the number of new HIV infections, if you put them per average population per year. However, because we are also getting young people converting or growing into old age, this is not helping us to see the prevalence going down. So the HIV prevalence is still at 5.1. In 2020, when we developed this plan, the HIV prevalence was at 5.5%. So it has reduced to 5.1. But the other indicators that we are looking at more keenly is the number of new HIV infections. And Honorable Minister, I am reporting that the number of new HIV infections is not reducing as we would want. It's reducing, and that's progress, but we can say to see new HIV infections reduced to 10,000 per year by 2025. We are still seeing 51,000 new HIV infections. We are also noting that AIDS-related deaths have stagnated in the last 3 years at around 17,000 Ugandans dying per year, which translates to about 300 Ugandans dying each day. Honorable Minister, in terms of coverage with antiretroviral drugs, we set out to attain 95, 95, 95, meaning that 95% of people living with HIV and AIDS know their HIV status by 2025, and that of those who know their HIV status, 95% have been put virally suppressed. Honorable Minister, this report shows that we are not at 95, 95, 95. Who are living with HIV know that they have it, they have tested, and they are aware. And those who are aware, then 94% have been started on treatment, and 94% of those on treatment are virally suppressed. So the gap is on the first 90. We seem still not to be able to get people. The 10% is still elusive. We need to get them if we are going to end AIDS by 2030. But more importantly, Honorable Minister, is that when you look at these figures and categorize them by young people and adults, we seem to be leaving behind the young people. Because the young people, for those who know, they tested and know their status, they are at about 80%. And also those who are adhering to their medication and therefore benefiting from the medication are low. We have made progress. We continue to identify and test more people. 6.8 million Ugandans tested last year, and of those 142,000 tested HIV positive. And 88% of those who tested HIV positive were put. And collaboration we have with all our stakeholders, as can be witnessed by the representation in this hall. As Uganda AIDS Commission, we have revitalized engagement with stakeholders, both at the national and at the subnational levels. We are engaging cultural institutions to reach, through them to reach the people. We have engaged and are continuing to engage with higher institutions of learning, as you heard from the testimony of the young person. But also, Honorable Minister, we are engaging through the leaders, as you are aware, to also be able to disseminate approved HIV prevention messages through their radio communication. Honorable Minister, we have also made great of the government institutions now are able to plan for HIV interventions. They allocate 0.1% of their budget towards HIV interventions, and most of them are submitting their reports to Uganda AIDS Commission. And last but not least, we are seeing that government of Uganda's contribution towards the HIV response is sluggishly increasing. Last year, government of Uganda contributed 14% to the national, to the costs of providing HIV services. And this time around, this increased from 320 billion Uganda shillings to 358 billion Uganda shillings, which is equivalent to 14%. So the major gaps, Honorable Minister and members present, is that we seem to be leaving children and adolescents behind. We have noted that 35% of new HIV infections are occurring in unmarried women. From there are actually young mothers, less than 24 years of age. If we continue with this, of course, then it means that our dream of reaching 95, 95, 95 and ending AIDS by 2030 may not be realized. We are also seeing increasing proportions of individuals with multiple sexual partners. In terms of behavior, Honorable Minister, people are using less condoms compared to 100 at risky sexual behaviors are on the increase. So this needs to be addressed through intensified behavior change communication and messaging to make sure that we leave no one behind and we reach everybody. Honorable Minister, the other big challenge that I want to bring, and there are many challenges, but I'm picking just a few that require your attention. The second big one is the inadequate financing of the HIV response. We are putting people on treatment, and the care and treatment component seems to be fairly funded. But the prevention component of the response is underfunded to ensure that we are able to disseminate messages. We know that mainstreaming is making a contribution. Our RDCs are making a contribution. The cultural institutions and religious leaders are making a contribution. But all these need concerted efforts and more efforts in order for us to realize, to be able to cross the tap and realize the reduction in new HIV infections. Honorable Minister, allow me to end here. This is so far what we've been able to compile in the report. We have a team of rapporteurs who will compile the report from, maybe I should have briefed you, Honorable Minister, that in addition to this big tent, we have breakout sessions and we are discussing scientific papers. So we have scientists who are also advising on the best way to prevent or to manage HIV and AIDS in Uganda. So all this will be compiled into one comprehensive report, which will be brought to your office. I thank you, Honorable Minister, for coming, and I thank you for coming.
Round of applause for Dr. Bagambe Vincent, who has ably represented the Director General Uganda AIDS Commission. And you've all heard the statistics and the nation is doing. It remains a fact that ending HIV is a responsibility for all of us. Though the same is my responsibility towards ending AIDS by 2030, I think the mantle is supposed to be carried by all of us if we are to hit the target. At this moment, without wasting any minute, allow me to invite the UNFPA country representative who is going to give us the keynote address on ending the HIV vulnerability dilemma among adolescent girls and young women, and what we need to do better than what we've been doing. Sir, you're welcome.
Thank you. Honorable Babalanda, Minister in charge of the Presidency. Honorable Margaret Aibare, Chair of the Session, Member of Parliament. Chairman of the Uganda AIDS Commission, Dr. Eddie Sifuluya. Representing the Director General of the Uganda AIDS Commission, Dr. Vincent Bagambe. Ambassador of the United States of America to Uganda. Heads of agencies here present, senior government officials here present, bilateral and multilateral partners here present, civil society partners, a network of people living with HIV, UN agencies here present, implementing partners, ladies and gentlemen, all protocols observed. Good afternoon. As UNFPA, as the chair of the AIDS Development Partners Group, I'm very pleased to be here, of course, with all of you today to deliver a keynote address on behalf of the development partners on our collective responsibility to end the HIV vulnerability dilemma among adolescent girls and young women. It goes without saying that Uganda has long been a leader in the fight against HIV, with significant and remarkable success, both globally and regionally. This certainly would not have been possible without the leadership of the Ministry of Health and the Uganda AIDS Commission, and the indispensable support from PEPFAR, Global Fund, the private sector, the UN family have all laid out the progress we have made thus far, the challenges in front of us, the recommendations to move forward with such clarity and knowledge. So I will certainly not be repeating any vulnerable populations that is affected by the HIV/AIDS epidemic here in Uganda, and explain why this vulnerability persists and what we can do collectively to address this issue. In 2000, HIV infections, 15,000 out of the 20,000 were among adolescent girls and young women. This translates to 4 out of 5 HIV infections occurring among the adolescent girls and young women age group of 15 to 24. Young people are certainly looking at us and putting us to task to address the scourge. They're asking us to leverage on each other's strengths, coordinate our efforts, be deliberate and consistent in our approach, use the latest innovations, and recommit ourselves to tackling adolescent girls and young women's vulnerabilities holistically and comprehensively. You asked what we need to do better. We, as the AIDS Development Partners Group, believe that HIV prevention efforts from both a biomedical and structural perspective need to address persistent gender inequalities urgently. Honorable Minister, Excellencies, ladies and gentlemen, we have a narrowing window of opportunity to end AIDS for all adolescent girls and young women by 2030. 4 decades of game-changing scientific breakthroughs and program interventions have given us the knowledge we need to accomplish this. Allow me to share some thoughts on ways to address these gaps. Reducing teenage pregnancies. In Uganda, the weighted pregnancy prevalence among adolescent girls and young women aged 15 to 19 years is alarmingly high and has stagnated at 24 rates. In 2023, 250 children aged below 15 years, the unmet need for family planning. Similarly, adolescents aged 15 to 16 years have an early sexual debut, with 1 in every 10 girls, around 20%, engaging in sexual intercourse by 15 years of age. We need to remove the barriers that continue to make this age group vulnerable and provide adolescent-friendly services to increase access to existing sexual and reproductive health services, including HIV. Learn about their rights, develop the skills they need to succeed in life, and to protect themselves, of course, from harmful practices such as child marriage, HIV infection, and other STIs, as well as FGM. Evidence from other countries show that if girls are able to stay and finish secondary school, their risk of getting HIV can be reduced by up to 50%. We know enough to say that harmful sociocultural practices disproportionately and continuously make young women and adolescent girls more vulnerable to HIV, prevalent in Uganda. About 20% of teenagers aged 15 to 19 years are being married or living laws. We must work together with the government to change the mindset of communities, traditional and religious leaders, and to collectively work towards changing the negative gender norms and other associated negative practices that make young girls vulnerable. We need also to advocate for policy changes towards appropriate and proven solutions that will reduce the number of new HIV infections and AIDS-related deaths, but also, of course, ensure the effective implementation of programmatic interventions. This is absolutely a must. Let us also not forget the knowledge gap among young people and adolescents when it comes to HIV. Comprehensive HIV knowledge among young women aged between 15 and 24 remains low at 56%. Poor skills and insufficient resources mean that young women remain unprepared to make safe and healthy decisions regarding their sexual and reproductive health. So let us make sure that the knowledge gap is addressed by providing platforms such as social media, for instance, to raise awareness and improve comprehensive knowledge about HIV and sexual and reproductive health. Of course, we must also take advantage of new technologies. Everyone here, including communities, should take the responsibility of advocating for the use of new technologies to be rolled out without this vaginal ring. Finally, I briefly touched on the need for an approach that also to sustain the response and end the AIDS epidemic here in Uganda. The community and constituency of young women and adolescent girls and young people in general are an integral part of the movement in resolving some of the persistent challenges that continue to make them vulnerable. Young people have spoken through their various platforms, including the Uganda National Young People's Association and the Youth Situation Analysis report recently, on how they want to be involved in a meaningful manner. Overall, young people are calling for increased involvement in the design of interventions that are meant for them, right from program design to implementation and monitoring. Youth involvement will increase the level of ownership amongst the youth, as well as transparency and success. Uganda has much experience working with communities to manage significant health challenges, including pandemics. We have seen it with COVID and with Ebola. So it is indeed vital that we empower communities, including young women-led organizations, to take a lead in addressing these same vulnerabilities of their communities. This year's World AIDS Day calls upon putting communities in the lead. The theme emphasizes that we can end AIDS as a public health threat by 2030, but only if communities are fully included and are sufficiently funded to lead the way. It highlights how underfunding and harmful barriers are holding back the life-saving work of these communities and obstructing the end to AIDS. Excellencies, ladies and gentlemen, as I conclude, let me also express my immense gratitude for the progress made, who have tirelessly worked with partners in the planning and execution of the HIV response in the country. I would also like to thank the frontline workers. And finally, a round of applause, please. And finally, let me extend my sincere appreciation to the development partners for the support that has collectively contributed to the government-led efforts to lay ground for the targets of ending HIV/AIDS as a public health threat by 2030 and create an AIDS-free Uganda. Together, we have the power to empower adolescent girls and young women by the data to scale up our successful efforts efficiently. Together, we can make a real difference in tackling the vulnerability of adolescent girls and young women and building a better future for all. I thank you all and look forward to a fruitful symposium. Thank you very much.
Thank you so much, our UNFPA country representative, for this elaborate, keynote address. Young people are looking up to us. We need to reduce teenage pregnancies. We need to provide adolescent-friendly services. And we also need to work hard and ensure that we change people's perceptions as far as HIV is concerned. We are responsible for the policies and laws in this country, but I want to say this, that even if we put beautiful laws and policies in place, the most laws begin with families, clans, communities, and societies. We need to work hard and change people's perceptions if we are to end HIV by 2030. I want to take this singular honor and opportunity to invite His Excellency William Pope, the U.S. Ambassador to Uganda, to come here and give his statement. You're welcome, Your Excellency.
Honorable Minister of the Presidency, honorable ministers present, and honorable members of Parliament, representatives all of the Ugandan government, ambassadors, heads of missions and development partners, Director General of the Uganda AIDS Commission, religious, cultural, private sector, and civil society leaders, distinguished guests, ladies and gentlemen, all protocols observed. Good afternoon. I am honored to attend my first National HIV Symposium here in Uganda and to have the opportunity to highlight the tremendous and lasting impact of our cooperation together, particularly through the PEPFAR program, which is celebrating 20 years since its creation. Among all U.S. government programs, PEPFAR is one of the clearest demonstrations of the power of drawing scholars, researchers, scientists, engineers, and others together to find bold, innovative, and audacious solutions to big challenges. The world-renowned musical artist and activist, Bono, who has been an important voice in the global fight against HIV and AIDS, noted that PEPFAR is, quote, the most eloquent expression of American values anyone can think of in recent times, the most brilliant outpouring of American ingenuity. Now, of course, we have much more work to do through PEPFAR and through our overall cooperation in fighting HIV and AIDS. But many of you will remember the early days when HIV/AIDS was actually a death sentence for virtually every person that tested positive. Fortunately, over the last 20 years, together with partners around the world, PEPFAR has saved more than 25 million lives and dramatically improved the health outcomes in more than 55 participating countries. Here in Uganda, of course, the theme of this year's symposium is mobilizing everyone to take collective responsibility while ensuring social accountability if we are to truly end equity and accountability. Great strides, but over the years we've also identified a number of challenges and commitments that we need to make to overcome. So is including that it is essential to add equity to the pillars of accountability, transparency, impact that are guiding us in our efforts against HIV and ensuring that treatment programs reach everyone. In particular, laws and practices that discriminate against anyone that is seeking health services work against our efforts. We must prioritize adolescent girls, young women, and key population groups that are at increased risk for contracting HIV. As many of you know, the first national HIV/AIDS control program in Africa began here in 1986, and Uganda was the first African country to begin to reverse its HIV epidemic. Over the past decade, the number of people contracting HIV has fallen significantly, but Uganda's HIV infection rate is still one of the highest in the world. Sadly, HIV infections are not declining as rapidly among adolescents and clearly disproportionately impacted by HIV, with 2/3 of adolescents diagnosed with HIV being girls. HIV prevalence among sex workers is estimated also to be very high at over 35%, as well as 14% among men who have sex with men, as well as 35% among fishing communities, among other vulnerable populations. Meanwhile, national data indicate that at the end of September 2023, over 1.4 million people living with HIV were on treatment. That is the power of PEPFAR and other programs and the collaboration that we have to save lives. The same Ugandans to focus attention on the areas where gaps do still exist. As the theme of this event indicates, equitably addressing every person who requires health services is key if we are to sustain the progress that we've already made. Evidence shows that laws and policies such as the criminalization of HIV transmission and same-sex relationships hamper HIV response and people's access to stigma-free sexual and reproductive health services. Instead, information-based efforts, including age-appropriate sex education and targeted HIV prevention campaigns can reduce HIV infections, as can also addressing domestic partner violence, which remains a significant social driver of HIV as well. Issues discussed over the next few days in this symposium should not only demonstrate solidarity and commitment to end HIV/AIDS related deaths by 2030, but also a commitment to act, make changes, and advocate for what we need. We can do many things. We can reach the global 95-95-95 treatment targets for all ages, genders, and population groups. We can also close equity gaps for priority populations, including adolescent HIV infections dramatically through effective prevention and treatment in support of UNAIDS targets. As we think about the people living with HIV and the young people here today in particular, I would like to reinforce what matters most is not the numbers only, but rather the names, not the statistics, but the stories, the lives forever altered for the better, the chapters rewritten, and the futures restored because of HIV treatment. The tools provided by PEPFAR and other programs of cooperation and our partners have helped to prevent, treat, and control this disease. We should be proud of the tremendous progress we have achieved, but again, our work is not finished. New data from UNAIDS on the global HIV response reveals that years of the COVID-19 pandemic and other global crises have slowed the progress in fighting HIV and AIDS in recent years. Millions of lives are at risk as a result. In addition, because of stigma, discrimination, and other structural factors, thus, we remain, as the United States, deeply committed to ending HIV everywhere by engaging and empowering communities and ensuring that our programs, research, and policies are informed by the voices of the people most impacted by HIV. Why? Because the HIV epidemic does not exist in a vacuum. Ugandans, including people living with HIV and AIDS, have health needs beyond HIV prevention and treatment. And we have seen that in the battle against the most recent pandemic of COVID-19, the platforms built for PEPFAR were critical for fighting it and for fighting Ebola. This is why PEPFAR has worked to build health systems equipped to adapt to the threats of HIV/AIDS, but aware that after the implementation of the Anti-Homosexuality Act in May of this year, the U.S. government paused the PEPFAR Country Operational Plan, or COP 2023. That approval process was paused in order to review and better understand the potential implications of this legislation. And the United States remains profoundly concerned about the AHA and any instance of its implementation. As stated by President Biden in May, we will continue to call for the immediate repeal of this legislation. However, ultimately, the COP 2023 was approved to move forward to ensure life-saving assistance continues to benefit all people in Uganda. However, this assistance will advance with restrictions on certain direct funding to the government of Uganda, as well as limitations due to the concerns about the harm of the AHA on human rights and HIV response. The new restrictions are not intended to impact service delivery, and the U.S. will continue to be committed to serving all people in Uganda without discrimination. In alignment with U.S. law and efforts by the U.S. government to prevent discrimination based on race, religion, gender identity, or sexual orientation, we will continue to ensure that principles of non-discrimination are upheld in all PEPFAR programs. In accordance with these requirements, we seek to provide services to all populations and maintain equitable access for all in the fight against HIV. Finally, to better expand access to HIV prevention, treatment, care, and interventions, PEPFAR has reimagined its strategic direction based on extensive partner and stakeholder input to focus in the following areas. First, broadening HIV/AIDS conversation beyond the health sector and engage directly with national HIV/AIDS planning and coordination structures. Secondly, to strengthen national health systems for HIV and related health security capabilities, to promote public health security and responsiveness for all. To achieve this, Uganda will, of course, need robust national surveillance of HIV/AIDS and other public health threats and strong laboratory networks that support timely diagnostic testing and public health responses. Third, we will continue to commit to evidence-based and data-driven programming. The history of disease control has taught us that the last mile is always the most difficult. Closing the gap will require embracing and elevating the best new scientific innovations and ensuring that programming is data-driven. We are closer than ever to reaching the United Nations Sustainable Development Goal of ending the global HIV pandemic as a public health threat by 2030, and the U.S. is committed to working with the Ugandan people and other stakeholders, including the Global Fund to Fight AIDS, tuberculosis and malaria, and UNAIDS. However, to sustain the gains made toward epidemic control, we must invest in approaches that strengthen equity and service delivery, remove legal barriers, shift harmful social and gender norms, and reduce inequalities. Laws and policies that are based on public health evidence and protection of individual rights are not only the foundation of enabling legal environment, but it can also magnify the impact of any country's HIV response. Epidemic control will also require a multi-sectoral approach, and supporting populations in need can be reached equitably. Until we reach our goal of epidemic control, PEPFAR in the United States will work to serve as a light of compassion, care, and collaboration, with the wherewithal to fulfill our most basic human commitment, to preserve health and to save lives. The legacy of this bold initiative, now 20 years on, will continue to show what it means to do big things to address big challenges. And here in Uganda, the United States' commitment to work with the Ugandan people to deliver a more prosperous, healthy, and peaceful Uganda. Thank you very much.
Thank you so much, Your Excellency, for the statement that you've given to us. And I want to take this opportunity to thank you and the U.S. government for the continued support given to us as government of Uganda in fighting HIV and AIDS. And I want to say this, that we cannot fight HIV and AIDS without the key populations. How are our programs targeting the priority populations and key populations service we are to fight HIV in this country? It might not be your take home, but I believe it will be my take home as a member of parliament. And without more ado, I want to take the opportunity to invite the chairman, Uganda AIDS Commission Board, Dr. Eddie Mukoyo, to give his remarks. I thank you.
Thank you very much, Master of Ceremony. Our guest of honor, Honorable Minister for the Presidency, Your Excellency the Ambassador, U.S. Ambassador to Uganda, the chairperson of the UN AIDS Development Partners, PEPFAR, and the support we enjoy from U.S. government, the Honorable Member of Parliament who has been with us as the Master of Ceremony for this session. You made me sure that he's here, but you people don't know how to clap. Let me show you. Asante sana. Because it was a long, tall order for her to be here. We are very grateful, Honorable Minister. And let's also give the same applause to His Excellency, the Ambassador. This is his first mission function. Asante sana. Then, of course, Asante sana. I know that we've, in the interest of time, I'll not go into my remarks, but thank most sincerely our guest of honor for making it and officiating at this opening ceremony for the symposium. allow me just to hand over this mic to the Honorable Member of Parliament, who is also a member of the HIV/AIDS Committee, representing the chairperson. You're most welcome. Thank you.
Thank you so much, Chairperson Board, Uganda AIDS Commission, for this opportunity to first of all thank you, my Honorable Minister, for taking out time on your busy schedule to come and grace this occasion. It's not, we can't take it for granted. I know how busy you are. And I want also to thank the Honorable Minister in front of you, because I sit on the committee of HIV and AIDS in Parliament, and time in, time out, we call her to the committee to speak about HIV, AIDS, and related matters. And I want to tell you that she has ably represented the Uganda AIDS Commission on matters of HIV in this country. I want to thank you sincerely before this congregation. And I want to take this opportunity to invite you to come and give your speech and officially open this second National HIV and AIDS Symposium. You're welcome.
Thank you, my sister, Honorable Member of Parliament from Mbarara District, Honorable Ayebale Margaret. Your Excellency, Mr. William Pope, Ambassador of the United States to Uganda's group, and the representatives of AIDS development patterns here present, representatives of implementing patterns, scientists and clinicians, representatives of people living with HIV, representatives of religious and cultural leaders, representatives of local government leaders, representatives of civil society organizations present, colleagues from ministries, departments, and agencies present, representatives of the media, Honorable Member of Parliament, Mbarara, Uganda AIDS commissioners and staff, invited guests, distinguished delegates, friends, ladies, and gentlemen, good afternoon. My name is Babidi Emile Babalanda. By the grace of God, I'm the minister in charge of presidency. I bring you greetings from His Excellency, the President of the Republic of Uganda, retired General Yoweri Kaguta Museveni. More greetings from Mama, the First Lady, and Minister of Education and Sports, Mama Janet Kataha Museveni. It is with great honor and pleasure to be with you today at this great event, which brings together scientists, programmers, development patterns, civil society, the private sector, and the government representatives to give account to the Wananchi about the status and progress of implementation of the HIV response. I know that the scientists are here to exchange wonderful research, ideas, program innovations, and how best to solve the program challenges, how to improve treatment outcomes as we strive for a Uganda free of AIDS and its effects by 2030. I am delighted to be a part of this important gathering. I would like to thank the organizers for giving me the opportunity to share a few thoughts with you as we begin our work here together. Ladies and gentlemen, potential fast-track initiative to end AIDS as public health threat by 2030. As I stand here today, the prospect of a Uganda with zero new HIV infections has never been as real as it is now. Time-proven social behavioral approaches like abstinence and being faithful, combined with the new tools and discoveries like use of condoms, like what my colleagues have been mentioning on it, safe male circumcision, and ARVs are providing people with a real chance of protecting themselves, hence preventing HIV transmission, or where already infected, a chance to live near normal lives. All of us present here today have a role to play in ensuring that the President's initiative and the people's aspirations are realized. Fellow Ugandans, there is much to celebrate about in this fight against HIV and AIDS. New HIV infections have declined by 35%. Elimination of HIV transmission implementation that are simple and cost-effective. Friends, HIV care and treatment is expensive. We can't afford it in the long run as a country. We have no choice but to work harder to prevent any new HIV infections. Towards ending AIDS by 2030. Indeed, it will take all sectors of all societies, public and private, working together to achieve the goal of ending AIDS as a public health threat in Uganda by 2030. His Excellency the President has made his part. Government and the donor friends have done their part. But without each individual taking their responsibility to protect themselves or to seek for care, we shall not end this epidemic. I would like to thank all the stakeholders for making your contributions using the multi-sectoral approach. Uganda was the pioneer of this approach, and other countries learned it from us. Let us continue using this approach to provide the services, but also to reach out to the people to take personal responsibility for their health. It is certainly true that over the last few years, we have made great progress in HIV and AIDS care and treatment. But the sad truth is that these new HIV infections every year make our hope of ending AIDS by 2030 fade away. The cost of providing services cannot keep increasing, straining our economy even more. Clearly, we have much more work to do if we are to achieve the ambitious goals in the Presidential Fast Track Initiative. I should also add that HIV-related stigma and discrimination, as well as gender-based violence, continue to fuel this pandemic and drastically hamper our prevention efforts at all levels. We must address this pandemic with all its complex challenges if we are to slow the high numbers of new infections and provide care and support for the millions of people already living with HIV and AIDS. The government of Uganda has, since the outbreak of the HIV epidemic, recognized its role as a leader in this fight, and we will continue to actively support all interventions aimed at ending inequalities among adolescents, girls, and young women and boys, and to work to enhance our efforts in the battle against AIDS domestically. To make the vision of ending AIDS a reality, we must all work together. The government ministries, departments and agencies, local governments, development partners, the private sector, people living with HIV, religious and cultural leaders, civil society organizations, the media fraternity, and academia. It is everyone's responsibility to contribute to this fight against the greatest public health crisis in centuries. And finally, we cannot win the battle against AIDS unless we deal with the best weaknesses of poverty and gender inequalities. Access to basic education for girls is in fact AIDS prevention. Access to microcredit loans and opportunities for women is in fact AIDS prevention. The list goes on and on. If we are going to be successful, we have clearly laid this foundation with the success of mainstreaming HIV in all government development programs. I challenge the non-government organizations in Uganda to also mainstream HIV in your programs. Last but not least, ladies and gentlemen, this symposium is a great opportunity to dialogue and to inspire collective action. May we all seize this moment to learn from each other, build lasting partnerships, and take the actions so desperately needed in our shared fight against HIV and AIDS. As the Minister directly supervising the coordination of the HIV response, I wait to receive a full report with clear actionable order. For this, we thank you very much. It's now my honor and privilege, ladies and gentlemen, to declare this second National HIV and AIDS Symposium officially open. Thank you for your kind attention for God and my country.
Thank you so much. I want to take this opportunity to hand over the microphone to the day's MC, who will, I think, take us in the next program. I thank you so much. Thank you for being with me as I took up the chair of the session this afternoon.
All protocol observed and our distinguished guests, we have come to the conclusion of the first day of the symposium. And in less than a minute, allow me invite the U.S. government staff to join us here for a photo. Just a minute. The Chairman, Scientific Committee, Dr. Tindieba, the Acting Director General, a representative from the PLHIV Network, young person, and then CSO representative. Kindly join us for a minute because our delegation wants to leave. Chair and the Board Uganda AIDS Commission, PLHIV representative, CSO representative, and then we had Pepper. Yes, the team is here. So all our cameras set because we don't have time. Dr. Dennis, we are also asking you to join. Is the young person here? Thank you. Okay. Yes. Cameramen, are we set? 1, 2, 3, and go. I'm not seeing CSO representative, so I'll stand on behalf of CSO. Are we done? And then, can you please play for us the national anthem as the Honorable State Minister? Yes. In reverse order. Thank you.
Thank you so much, each and everybody. Thank you, Honorable Minister, for gracing this occasion. Thank you, Your Excellency, the Ambassador of the United States to Uganda, our distinguished of honor to go and inspect the activities that are taking place outside of this tent. We have the Fire Retire tent. Maybe Your Honorable Minister, if you can go to the Fire Retire tent, and then we have other exhibitors. If you find time, we will appreciate. Okay, the ambassador is not. Okay.